So I'm going to move on and talk about our first theme. We've got three different themes to talk about. And the first theme was really about whether young people feel heard and whether they feel their distress is acknowledged. And we're talking about a number of different kind of communication practices here. And these involve, on the left here, we've got acceptance, and I'll show you what this looks like in some of our videos and transcripts, because it sounds a little bit, motherhood and apple pie, but actually we really need to break it down to look at what does it actually mean when we look at communications or these kinds of communication and these kind of settings. So we're talking about accepting what people are saying. We're talking about validating what people are saying. We're talking about empathizing with the distress that people are in. And this was what what the Young People's Advisory Group picked on as one of the most striking absences in the video data was the lack of empathy. And then really importantly, we're talking about not judging people. So I think often what we're seeing by when people feel that they're heard and understood, it means that they don't feel judged. And unfortunately, a lot of young people do feel negatively judged for seeking help. And this is a quote from one of our young people who said, by kind of bypassing those feelings, so when young people talk about how they're feeling, it's kind of like almost implicitly telling the person, okay, your feelings are a problem. I'm uncomfortable with your feelings. We're not going to talk about them. We're just going to fix them. This almost amplifies the young person's distress because they're struggling to sit with the feelings and they're seeking help. So the lack of kind of validation can have this knock-on effect of almost amplifying distress. So the next thing I'm going to do is actually just a quote, which nicely illustrates the role of nonverbal communication. So when the eyes say one thing and the tongue another, a practice man relies on the language of the first. So really, we're also talking about what's the role of nonverbal communication here, because sometimes when people when you see a transcript of what's said, it doesn't give you the full sense of what that communication is really like when you take into account all the nonverbal aspects. And people might kind of say that, okay, they said those words to me, but the way in which they said it means that, they gave me an implicitly different message. So the first video I'm going to show you today is an example. We're going to show an example of maybe where distress is downplayed, and then an example of where it's not and where the distress is validated. So this first video is, we're calling him Jack, who's a young man experiencing suicidal thoughts. He has been referred from a university counselling service. At the start of the video, he says he feels miserable. So let's have a listen.
I feel like miserable kind of sums it up. And yet in your face, yeah. When you're speaking, you have a variation, haven't you, of your expression. You smile and things like that. Yeah. So you have times when you clearly aren't miserable. You're sort of enjoying things, or you're able to give the impression that you are, yeah, enjoying things.
Well, maybe what I'll just quickly talk you through actually is this transcript. So before we go into the next videos, so we can see that the young man says, I feel like miserable kind of sums it up. And the practitioner then responds saying, and yet in your face, when you're speaking, you've got a variation of your expression, you smile and things like that. And the young person says, yeah. And the practitioner says, so you have times when you clearly aren't miserable, sort of enjoying things. Patient says, young person, which is a very minimal, the most minimal form of acceptance. And the practitioner continues, you're able to give the impression that you are enjoying things. So what we get here is we get a kind of a contrasting approach to our contrasting description of the patient's experience. So it is not accepted and it's not validated. And I look forward to the further discussion of your comments in the chat. So the next video is an example where the young person's distress is acknowledged. Sarah is a young woman who's presented after a suicide attempt, and she's just described having rapid shifts in mood.
It goes like this. You said it's kind of like something or nothing, but is it because you can't find the words to find, or is it because there's literally no explanation that you just feel so different once? Yeah. It'll just come over me, like, I'll admit it, sometimes I just find myself changing and then I'll be down again. Yeah, and I don't know why. It sounds like it's quite exhausting because it must sound like almost you don't know where you are from day to day even then. I'm fighting like every day myself. Yeah, I'm so tired.
So again, just another question for you. How does this video make you feel? What is your response to this video? What are you seeing in it? And while you're doing that, I'll talk you through the transcript. So we get the young person describing her mood swings, mood swinging between distress and apathy. And then we get quite a long description from an attempt to characterize that from the practitioner. You said it's kind of like something or nothing, but is it because you can't find the words to find? Is it because you can't find the words, or is it just there's literally no explanation that you feel so different? So we get a real attempt to kind of explore this further and find out from the patient's point of view whether this captures her experience. The young person nods, the practitioner says yeah, the young person says yeah, so we can see acceptance here, and the practitioner says yeah again. The young person continues, so we get this elaboration of how she's feeling. It'll just come over me, and I'll just find myself changing, and then I'll be down again, and I don't know why, and her voice breaks at this point. So we get this kind of struggle to understand why, so a search for meaning and understanding what's happening. And the practitioner says, it sounds like it's quite exhausting. So we get this validation about what the impact must be for this on the young person. And the young person nods. And the practitioner continues, because it sounds like almost you don't know where you are from day to day even. So we get this further kind of extending by the practitioner about what it must feel like for the young person. And the young person says, I'm fighting myself every day. Yeah, I'm so tired. So we get this real kind of elaboration and continuation of how the young person feels and the impact on her. So now I'd like to hand over to Lisa, to Rachel, who's going to ask some questions of our panelists. Thank you.
Okay, thanks, Rose. And I am aware of the time. So if I could ask our panelists, if you can, keep your answers to 2 to 3 minutes, that would be super. So my first question is for Catherine. So Catherine, can you tell us when have you felt acknowledged and validated by a practitioner, and what difference did this make to you?
First of all, can everybody hear me? Okay, good. I would say a time when I felt acknowledged by my GP actually was when I attempted suicide when I was 18 years old, and I had to go and see the GP, and my GP was the one that said to me, Catherine, you're not crazy, you're just going through a hard time. And that for me, I felt acknowledged, and I didn't feel so alone. I felt like I was a human being and not just the problem. And it meant so much to me. It meant so much for my recovery, because he didn't just like dissect the problem, which was like suicidal or depression, etc. Like he mentioned the positives about me, like, Catherine, you're intelligent and you're just going through a hard time and you're just reacting to it in a normal way. And like everybody reacts to hard times in different ways, but yours is still acceptable. You just need a little bit of help and guidance. And that for me, it meant so much. Like 7 years later, it still means so much to me. So definitely felt super acknowledged by my GP.
Thank you so much, Catherine. As I say, the fact that you're still thinking about it now shows how much that interaction meant to you. Michelle, I'm going to jump onto you because I know that did you have something to add here to this section?
Yeah, I think going off what Catherine said, and thank you for sharing that and being so open. When a mental health professional validates you and says things like, it sounds like life has been really challenging for you, but you have been going through a really difficult time. Hearing them say something like that can help to soften or reduce that inner critical voice that a lot of us can have that might be telling a young person with mental health difficulties, oh, you're being overly sensitive, you're just too weak, you're blowing things out of proportion, you're making this up in your mind. And through validation, those like that voice and that volume gets toned down. And it's really powerful for someone else to just see your pain or distress as real. It's not something that's just within you. And on the practitioner side, I think when you validate a young person, they will feel safer and they won't feel so judged by you. And because of that, they're often more willing to open up and share their experiences and share their struggles with you. And that's really beneficial for the practitioner because they get more information about the young person's situation and get a better idea of how they can support them. So I think validation is really powerful for the young person and professionals as well. And it should really be used more widely and encouraged more intensely, I suppose, in training.
Thank you, Michelle. Yeah, sometimes just going to that GP for the first time and taking that first step could be so scary. So being validated can mean the absolute world. Okay, I'll jump on to our next panelist now. So this one's for you, Richard. So my question is, in your practice, how do you show people that you hear and acknowledge their distress? And could you give us examples?
Hi, yes, well, we've had some great examples already. I just wanted to think about kind of 3 or 4 quite difficult situations. So sometimes an individual is really very distressed and emotionally very up there. Other times they can be very withdrawn. In that situation, sometimes it's really important to try and bring them to that point of being able to think, because if they can think, then they can believe that you might be listening and understand that. So and I've been very influenced by kind of mentalization techniques in thinking about that. So if someone's very up there, then slowing things down and trying to ask questions about one thing in particular, and let's just take one of those examples and get some detail from it. If someone's very withdrawn, then it can be really hard because they may have lots going on but give the impression of not really caring. And again, you've got to try and elicit get some sense that the individuals get them to trust you so that they want to talk. So firstly, you can ask some very basic questions. Just, I'm really interested, tell me about what's been happening today, and let's think about some, how were you feeling? And then you might want to draw them into your framework of thinking. I'd really like to think together about what you're feeling, what you're thinking, and then how you behave. So almost kind of teaching them a framework so that they can articulate and then know that you've heard them. The other issues around trust that you've just talked about are really important, and trying to do things that show that you aren't judging, but there's a whole load of other things that an individual might be. So judgment is often talked about, but actually we never know what an individual is thinking. So being really open to the idea that an individual might be thinking all sorts of things about you, that you not just that you're looking down on them, or that you don't trust them, or you wouldn't believe them. So really try and pick up on what they're thinking from what they're saying, and say something very actively to offset that, to show that actually you don't think that they're stupid, or you don't think so. So really tapping into what they're believing and thinking. Another technique that I think can be helpful, which I think was touched on by the last speaker, is helping explain a situation. So not just normalizing it and saying that that's a normal response, but some people really find it helpful to know why things are like they are. So if you're emotionally very up and down, bringing in the neuroscience, talking about what's going on in the amygdala and the effect that trauma has on your ability to maintain an emotional level. So people understanding that can be really helpful, and I think that also helps to validate an understanding. And then lastly, I just want to, regarding neuroscience, I think thinking about brain plasticity is helpful. So helping people think about whether what they're feeling now is a constant. So looking back and contrasting how they are now with how things may have changed, to show that some things might have changed for them. And that sets things up for possibility of hope and agency for them to take some kind of charge.
Thanks so much, Richard. That was really, really helpful. I'll jump on to our final panelist for this section. Matthew, this one's for you. What do you think the barriers are for practitioners in acknowledging young people's distress?
Yeah, thank you, Rachel, and welcome all to the webinar. Yeah, I've been thinking about this quite a lot since watching the videos together with the research teams. It's been, I guess, a difficult experience as clinicians as well to see what happens in some A&E departments across the country. And until recently, I would be sitting there myself in A&E overnight fairly often doing some of this kind of work. So trying to think it through, I guess I was sort of beginning to think of sort of system level explanations and perhaps individual explanations. I guess one I was very much aware of when I used to supervise junior psychiatrists was the kind of, I have X people to see and there's an A&E waiting list target of Y, and I have to, see all these patients before a certain time. So there's an emphasis on doing things in a very ordered, structured, pressured way, I think, sadly. And one of my fears is that perhaps an element of bureaucratic process overtakes the more empathic and trusting process. I think is very important in the space to, I think creatively with young people and to sort of have that time for validation and test out ideas with them, as we saw in that second video. I think that's really important. So I think there's a bit of that. There's a tension that clinicians, perhaps for the intensity of the work, can find it very difficult. And I guess linked to that is also, again, we discussed this in our kind of research meetings, is the kind of responding to the distress when you're not sure what you do with it. Quite a lot of the discussions we had was around some of these A&E scenarios are very kind of dichotomous. It's can the young person be discharged home, or are we looking to admit this young person? So it's got a middle ground of how you manage distress. Is an uncomfortable space of uncertainty for the clinician to manage, I think, for them individually, and how they respond to that authentically. And that, I guess, leads me on to my sort of third sort of systemic point, is maybe we lack structures of supervision and reflective practice for some of these practitioners. And again, the pressures of work, some of these guys will be working 8, 12-hour shifts back to back seeing people. So how we can expect these kind of genuine, authentic, empathic responses to distress throughout that day without any kind of support reflection space, I think is questionable. So I guess that's one of my practical things I would suggest. And thirdly, and I guess the last sort of more individual thing, is that it can be quite hard to acknowledge this distress on a personal level. And that never really dawned on me until recently, until I've been seeing acute clinicians with COVID about the moral injury work. I think we discussed in our groups again, and seeing how our acute clinicians are struggling with making ethically difficult situations with decisions with scant resources. And I guess in mental health, that's the norm. We can't offer, very sadly, we can very rarely offer the patients what they need. We're always having to make difficult decisions about the care we provide. So I think a lot of people, so clinical staff may find some of this work harder than we perhaps realise. Not to defend what happens by any means at all, but I think there's a lot we should be doing better for our patients.
Yeah, no, and I think no one is saying this is easy for sure. But I guess the difference it can make, as Catherine and Michelle told us, is phenomenal. So hopefully these tips will help people. I think I'm handing back over to Rose now. It's a bit like pass the parcel this, to share some top tips for professionals on this section.
Thanks, Rachel. Let's see if I'm going to be able to transition to my slide. Okay, this time. Hopefully it should be coming. Can you see this okay?
Yeah, that's perfect.
Right. So I think obviously some of the really important points have just come up. And I think what the young people were saying is that I know we're under time pressure, so I need to move on quickly, but they're very, very aware of the pressure that staff are under. And just that simple acknowledgement and validation is so important. And, it doesn't cost any extra money. Obviously it does in terms of supervision and support, but in those encounters, I think sometimes staff said to us they've kind of lost sight of how therapeutic just that validation and acknowledgement is. So these are our top tips for starters. So just saying, I can see you're struggling and you are in distress, that can make all the difference. I still want you to acknowledge my distress, even if you can't offer me the services that you'd like to offer me. So that came across as really important. Don't downplay or contest what I'm feeling, like we saw in the first example. So really trying to recharacterize what I'm telling you. Just because I look okay doesn't mean I'm feeling okay, because this is one of the things that came up a lot in our discussions about what does it look like to be unwell, to be mentally, unwell? What does it look like to be suicidal? And people have kind of a certain assumptions that are not always met. And then the last was, I can tell if you're taking me seriously particularly by your body position and your tone of voice. So these are kind of, so it's not just what you say, but how you say it to me that really matters as well.